let's talk about the PSA a little bit because
Yeah.
we've alluded to it a number of times. So let's explain what it is, where it comes from, and more importantly, of course, how we use it.
Yeah. So PSA is a protein. It exists to aid in the liquefaction of semen. So it's produced by the prostate. And if one were to measure PSA in semen, it would be very, very high. I always tell people if you looked at PSA in the semen, it would be, 100,000 nanograms per milliliter of PSA in semen. It's designed to be there, and it exists there to liquefy the semen to help in the process of fertilization. It is not designed and it should not exist in the blood, but a certain percentage of PSA made in prostatic epithelial cells leaks into the bloodstream. And when we do a PSA blood test, we're measuring the PSA that has leaked into the bloodstream from a prostatic epithelial cell. Now, most of the PSA that leaks into the bloodstream is bound to other proteins. A certain percentage...
Is that like albumin mostly or sexual binding globulin?
Alpha chymotryptin.
Oh, so it's its own separate binding protein.
Yeah. That's the most common protein that PSA binds to, but it can bind to a family of 3 or 4 or 5 different.
But these are prostatic proteins.
Yeah.
Yep.
It's bound. Now, how much it's processed, because as you know, proteins just don't come out finished. They grow into their final state, and they grow by shrinking, right? They get things snipped off of them as they're maturing and going through that process. As PSA is evolving in the normal kind of development of its exocrine function, it gets snipped into smaller and smaller states. Fully processed PSA can float around in the bloodstream freely. That's free PSA. So if you have a benign prostatic epithelial cell, a lot of its PSA will be fully processed and ready to go in the ejaculate, let's just say. And if it leaks into the bloodstream, it can float around freely. You can measure it in an assay, and it's what we call free PSA. A lot of the unprocessed or incompletely processed PSA is bound to protein. Alpha chymotryptin is the most common one. And that is what we would consider to be when we do a measurement of, when we're looking at total PSA, you're measuring mostly bound PSA and some free PSA. And that ratio you and I use in our practices to help discriminate against PSA that's in the bloodstream that may have leaked from a cancer cell or may have leaked from a benign epithelial cell. Now, there are other siblings of PSA that are also produced in prostatic epithelial cells, of course, all in response to androgens. They're produced in those cells, and they can also leak into the bloodstream. And we use those in some advanced PSA-based blood testing as well. But in general, when we are measuring PSA, we are measuring the amount of PSA, this protein, that's leaked from a prostatic epithelial cell into the bloodstream. We can refine that value by saying how much is there and how much is free. If we have high amounts of free PSA, 30% for example, then we can have good reassurance that most of the PSA in the blood that you're detecting is from benign cells. When most of the PSA that you have in your blood is bound, very limited amounts of free PSA, that's a strong marker that there's something going on, i.e. that cancer cells are leaking the PSA into the bloodstream. Now, as I mentioned, you can also measure other byproducts, other types of free PSA or other sibling molecules to PSA. PSA is called HK3 or human kallikrein 3. You can measure, for example, how much of human kallikrein 2 is in the blood. And these are part of more advanced PSA tests like the 4K score or, for example, the prostate health index. These are both mathematical equations that predict probability of aggressive cancers, but they're built off of looking at not just the PSA itself, but the PSA and how much other types of processed PSA exist as well.
Let's go back and talk a little bit about the free PSA. Does the amount of free PSA that we would want to see to be more assured of a benign nature of the PSA vary by age and absolute PSA level?
Yes, it does. So we begin to use the kind of free PSAs and the free PSA ratios and all those things when PSAs have crossed over a certain threshold, right? Because
typically a lab, if your PSA is 1, we can't even get a lab to check a free PSA.
Right. That's right. Because we know if you're screening someone and your PSA is 1, then the probability of a prostate cancer that's lethal is incredibly low, right? So that's why they don't have the assay set up to check it. And oftentimes, or some labs will not do that, secondary default testing unless it's over 4, for example,
Yes.
or over 2.5. Our lab's set up to do everything at levels as low as 2. So you can get them at lower levels. But in general, the idea is, well, if your PSA is below 2, the probability you have a lethal prostate cancer is, less than 1 in a million. So we don't have to worry about that individual. And we really want to use the percent free PSA to discriminate individuals who have elevated PSAs and having it discriminate between elevated because of BPH and elevated because of a cancer. So yes, as you get older, your prostate enlarges. As we talked about, metabolic syndrome causes your prostate in large part to grow just because of the T to E ratios.
Mm-hmm.
As you get older, your prostate gets bigger. So we begin to use that as you get older and your prostate gets bigger, you can have a proportional rise in total PSA in your bloodstream just because your prostate's bigger and is leakier. But you can easily tease that out by looking at the percent free PSA. So if the percent free PSA is over 18 to 20, then you can be pretty well assured that that's likely not coming from some aggressive, bulky tumor.
What about with prostatitis when we see these huge spikes?
Everything goes
PSA?
up in those cases. But
does the free still remain disproportionately high?
Well, it's a good question. I don't use free PSA in people because I'm
you know
tracking
what the etiology is.
I'm tracking it. I'm literally looking for trends for coming back down to a new baseline.
Yeah.
So yeah.
Okay. Let's talk about 2 other ways we use the PSA, the density and the velocity. How do those work?
Yeah. So as I mentioned, as you get older, your prostate on average gets bigger, not for all men, but for many men. And when that happens, your PSA can concordantly rise because it's just your prostate gets bigger and it's equally leaky, so the PSA can kind of go up. Now, what we look at is the ratio of the PSA value to the prostate volume. And that, as you alluded to, is called PSA density. And in general, when I educate patients, I tell them, well, we want a PSA to be about 10% of the volume of the prostate or less to kind of be in a safe range. So if your PSA is 4 and your prostate's 40 grams, which is about average size for a 60, 65-year-old guy, that's a PSA density of 0.1. We know that is correlated with a low risk of having an aggressive prostate cancer. So when I'm looking at someone's case, I want to know what their PSA density is. If the PSA density in a young man, frankly, is more than 0.1, I get a little worried. Mm-hmm. If on an average age person, if the PSA density is more than 0.15, I start saying, let's do some additional testing. Mm-hmm. So you put everything together, but yes, PSA density predicts likelihood that you'd ever be diagnosed with prostate cancer. It predicts aggressiveness of a cancer if you're diagnosed with it, and it actually predicts your outcome if you have a prostate cancer. So the higher your PSA density, the more significant your disease will be.
So the faster it increases.
And the faster that your PSA rises, it is a canary in the coal mine to say, hey, you need to do some additional evaluation. Now, it doesn't mean you have prostate cancer, because I often have, and we share patients where their PSA went from 1 to 5, but they had, we tracked it and it came back down because they had a flare-up or inflammation in their prostate that made their PSA go. Sometimes we don't know why. Often we don't know why. But if you track it, you can see that. So whenever somebody in general comes to see me with an elevated PSA, the first thing I always do is just recheck it, because there can be transient rises in the PSA. Now, as you know, we have very similar practice. I don't just recheck the PSA. I always order advanced PSA-based testing. What does that mean? That is testing that involves looking at the percent free PSA and then other things like -2 Pro PSA for the prostate health index test, or the 4K score, which basically looks at different kallikreins and their ratios. So,
and you and I discussed these tests in great detail in the first podcast, so we can also refer people back to those so that I won't make you re-explain them. But it does surprise me that the official screening guidelines for prostate cancer don't make any recommendation on the use of PSA testing other than something benign like every patient should discuss this with their physician, which is a real cop-out in my view of what we should be doing. Is that?
Well, it depends on which guideline you're looking at. So the American Urology.
This is the guideline.
U.S. Preventative
This is the
Services
U.S.
Task Force.
Preventative Task Force and the CDC. And there's one other that is...
Yeah, the American Cancer Society, the American Urology Society, the National Comprehensive Cancer Network. They're a little bit more progressive. They really suggest that you should talk about the risks and the benefits of screening. They kind of skirt around the idea of, well, how do you properly screen for, well, AUA and the American Cancer Society don't get into details up front. They say start the discussion with, like, what's your potential risk for developing prostate cancer? You can ascertain that with the family history. Again, if you're reading the AUA guidelines or the American Cancer Society guidelines, you already have a leg up on the average internist, because an average internist is just looking at general things they learned in med school or the U.S. Preventative Services Task Force, which is too general and too vague. So I totally agree with you. I like and personally reference everybody to the National Comprehensive Cancer Network's prostate cancer screening guideline. That basically says that every man at age 45 should have a baseline PSA. Because as you mentioned, changes over time are key. They're critical. And you want to know where you are in relationship to the median, right? So a 45-year-old man's median PSA between 0.5 and 0.7, somewhere around there. Understand your median PSA. And then if your PSA is below 1, you could just get rechecked in 2 to 4 years. If your PSA...
But Ted, the test is free. It doesn't cost anything to do a PSA.
It is.
Why wouldn't we do this every single year?
I guess the argument against it is that there can be natural variations in again, if you're a smart physician, you're going to pick up that, hey, there's natural variations, and if it goes up from 0.7 to 1.5, I'm going to recheck it, and it's still in a safe range, et cetera, et cetera. I think that...
But isn't that all the more reason to do frequent testing if there's natural variation? Because it also means that if you're testing infrequently, you're more likely in the presence of natural variation to miss what the actual trend is. Like, think of the following thought experiment, right? So I love doing the thought experiment. So my thought experiment with colorectal cancer is, imagine you had a low-cost, zero-risk colonoscopy that you could do on somebody every month.
Yep.
Would you eliminate colorectal cancer? Yes. There'd be no such thing as colorectal cancer.
Yes.
Right? The third leading cause of cancer death is gone if you have that. Now, the reason we don't do that is they're not free and they're not risk-free. Yeah. Okay. Well, similarly, imagine you had, just like we have a continuous glucose monitor, a continuous PSA monitor you could slap on somebody's arm, and you could, for free, basically measure their PSA over their lifetime. I would argue there would be no such thing as lethal prostate cancer, because provided you had the AI engine and the physician to monitor this, you would know, Johnny rode his bike, Johnny had sex, Johnny, had a prostate infection, but you would very quickly be able to pick up signal from noise.
Yeah, I think I don't disagree with you. It's just a matter of how frequent, what is considered to be intensive PSA testing, right? And so
let's just say annually, right?
Well, annual PSA testing is very intensive. So all the trials that showed that screening for prostate cancer with the PSA test, those trials that tested whether or not that reduced deaths, which they showed it did by 20 to 25%, was PSA testing every 2 to 4 years. So that's the baseline. So what we do in the U.S.
But
is...
can we do better is my point. Because to your point, it's still the second leading cause of cancer death.
It is. And the real question is, which we don't know the answer to, is were those men that ended up dying of their prostate cancer offered early screening or not?
Yeah.
And we don't know that.
And then the other thing is, with a little bit more of an investment in knowing prostate size, if you could now get that prostate density. So now if you have from one blood measurement that costs less than a pack of gum, you know your PSA, you know your free PSA, you know your PSA density.
Yeah.
That's really powerful.
Yeah.
By the way, a 4K test is $1,000 test. You don't need to do it if you know PSA, free PSA, and PSA density.
Yes. And many would argue that
pack of gum, chiclets, those three things. Chiclets, those three things.
Cheap. They're cheaper than a pack of gum. But yes, I think, well, the PSA density is the more expensive part.
But you can get that off an ultrasound.
Which is free, basically.
It's free.
I mean, time for the
you don't need to do an MRI.
The bottom line, people would argue that percent free PSA gives you some of strong correlation between the size. Yep. So yes, I totally agree with you.
I'm just pushing back, Ted, because look, you and I want the same thing, but I view this as look, there are certain things that I don't see a clear step on the horizon for the elimination, right? Like I don't see an immediate step on the horizon for people not dying of pancreatic cancer.
Yeah.
I don't see, sadly, an immediate step on the horizon for people not dying, women specifically, of breast cancer. But I sure as hell see, with the existing technology, a reason for people not to be dying of colorectal cancer and men not to be dying of prostate cancer.
I mean, the deaths from prostate cancer with PSA screening have plummeted. So that's the one thing.
But it's still 35,000 men died last year.
And so the question
is, would they have not, how many of them would have been saved with traditional screening?
Yeah. And trust me, I'm trying to defend the rule makers that made these rules so that I was not involved with. But I would say that this idea of baseline PSA testing at age 40 on a population health level, where that all came about was from Bank serum out of Sweden, and so they were able to model that pretty well to understand what's your overall lifetime risk for developing or dying from prostate cancer. If your PSA at age 40 or 50 is below the median, then your lifetime risk is very low. Remember, so we have some information about it, and the modelers, this is the best that they could come up with. I'm not disagreeing with you. There's no reason in my mind why you should not get your PSA tested at an early age, understand your baseline.